Well, it's good to see you again. We talked about social assistance, public assistance. We talked about the relationship between public assistance, historically, and issues of public morality, the notion of who is deserving as a poor person and who is not, quote unquote, deserving. We saw that a lot of these issues start not just in American history, but actually go back 500 years, 600 years. We also saw that some of them are racially motivated in terms of how politicians use dog whistles to get people all concerned and riled up about the possibility that they, quote unquote, they, people different, are going to get some sort of social benefit and don't have to work. Certainly that's been the case since the late 1970s. We also talked about how a lot of employers would like to have as many people as possible in the workforce because that means they don't have to pay as much to attract workers. And so if they can make work a condition of getting any social assistance, so much the better. So we have a lot of cross currents that are moving in this domain of public assistance. And they change over time a little bit. And we saw that one of the changes, at least temporarily, was during the pandemic. Because, presumably, so many people were affected that the normal social contract or understanding of who's deserving, who is the deserving poor, was suspended in favor of getting aid to everyone, regardless of whether they were working, regardless of their position. Almost 93% of Americans got some sort of assistance, but we also saw that that ended. That was kind of an experiment. I referred to it as an experiment because what that experiment tended to reveal, as did another experiment we went over in this class, the Medicare and Social Security experiments, those experiments revealed that poverty is a policy choice. We'll see that again today. And by poverty being a policy choice, I simply mean that we could radically reduce or eliminate poverty if we wanted to. Now, there is a cost attached to that. Not only is there a financial cost, but there is also a cost in terms of what we call moral hazard. It may be that if people are treated too well, who are not working or who are not quote unquote needy, maybe they will not get a job. They won't try to improve their education. They may not do a lot of things that we as a society expect of them or want of them. Another theme that crosses all of the different issues we're talking about in this part of the course has to do with how the first 6 weeks of the course are exemplified in each of these policy domains. They are interrelated in ways that I hope you are exploring, if not in your sections, at least in your heads. And they are very real. I testified before the Senate Budget Committee that was interested, in fact, it held a hearing on an issue that we've touched on in this class, and that is, where is inflation actually coming from? Is it workers getting raises, or is it something else? And as the lead-off witness, I had the opportunity to make the lead-off framing of the issues. This is something else, another theme in this course. Whether I state it explicitly or not, you have to understand how issues are framed, what the choices are understood to be, are critically important in terms of our democracy and politics. But what I tried to get across to the senators was that the real issue is not wage price inflation. The real issue is price inflation and where that price inflation is coming from. The Commerce Department, Bureau of Economic Analysis, announced that corporate profits are at the highest level they have been in 70 70 years. So what I suggested to the senators, and I can only do this obliquely, you don't tell senators, you don't force them to listen, you just suggest to them. I suggested to them, very politely, that the notion that wages were pushing up prices when corporate profits are the highest in 70 years may not be exactly right. That if corporations were competitive with one another, going back to the first half of our course, when we talked about antitrust and competition and corporate dominance and the increasing concentration in almost every industry, if corporations were genuinely competitive with each other, they would not be raising their prices if they were sitting on a lot of profits, for fear that a competitor would rip away some customers. The mere fact that corporations can, with the highest profits in 70 years, raise prices and pass on any cost increases, whether those costs are supply increases, supply bottlenecks, wage increases, whatever they are, the fact that corporations can pass them through to consumers in higher prices and still maintain historically almost record profit margins suggests that maybe they are not very competitive. They are not under any competitive pressure. And it also suggests that maybe, just maybe, the answer to inflation may not be raising interest rates. Because if you raise interest rates, as we talked about, what you are doing effectively is slowing the economy. And who pays when you slow the economy? It's people in the bottom half or the bottom third who are the first to lose their jobs and also the last to get wage increases in a tight labor market. You see how all these dots are connected? Everything is related to everything else. So antitrust is important. And then we got into a whole discussion about windfall profits taxes, because several senators, Sheldon Whitehouse from Rhode Island, Bernie Sanders from Vermont, several other senators, have introduced legislation to deal with the windfall, quote unquote, windfall profits of oil companies and others right now. What do they mean by windfall profits? What they are getting at is that, again, although oil prices have gone up, crude oil prices have spiked, oil companies are making huge, almost record profits on top of those costs. And they are raising prices at the pump. They don't have to. They are doing it because they can. Are they morally blameworthy? No. This is the way the system works. They are responding to pressures from their shareholders. Remember the first half of the course? But that doesn't mean that it's good for the economy, it's good for workers, or it's good for consumers. In fact, it's probably not. So a windfall profits tax, in addition to antitrust, might be justifiable the way that Bernie Sanders and Sheldon Whitehouse and other senators are envisioning it, is it would look at their profits, not just the oil companies, but Bernie Sanders' bill would look at profits, the typical average profit between 2014 and 2019. And it would say that's the baseline. And profits in excess of that baseline, either half of them or 2/3 of them or 95% of them, would be taxed as windfall profits. And under Sheldon Whitehouse's bill, with regard to the oil companies, those windfall profits revenues from that tax would be remitted back to consumers in the form of quarterly dividends that you would receive. Not too bad an idea. We could debate it. There are problems administratively and every other way. But what I want to do is just give you a feel for how all of these issues are interrelated. My favorite part of the hearing came when Lindsey Graham started questioning me. He's the ranking Republican on the committee. And by the way, you know, in this class, I try very hard not to be partisan, and I'm not going to be. I'm just going to relate to you what we talked about. Because I was presenting all of these arguments, then Lindsey Graham asked, but, Mr. Secretary, they still call me Mr. Secretary. I think I have that for the rest of my life. Why not Professor? But, Mr. Secretary, I heard what you say, and I disagree with every word of it. And then he said, but what do you think about the problem of immigration at the southern border? Now, you see, these are the moments in politics and in the public sphere of politics that you yearn for. Because what Lindsey Graham was doing is what all politicians do, particularly if you're a senator. You reframe the issue as fast as you can. So it's not about corporate power. It's not about corporate profits. It's not about what anybody might call profiteering at the gas pump or anyplace else. It's not about taking advantage of consumers. It's about the Biden administration's so-called failure to control immigration at the southern border, which has almost nothing to do with what the hearings are about. And so I very politely said, Senator, this is a contentious issue. I understand that. But when it comes to inflation, and then I simply repeated my thesis. And I continued talking about big corporations taking advantage of their pricing power to the point where Lindsey Graham said, okay, I got it. And he had to break me off. You understand the kabuki theater aspect of all of this? So today, we're going to be talking about another perspective, another set of policies, another set of issues. They seem very different, and they are different. But they intersect with a lot of the frameworks and questions and policies we have already been talking about. Today's outline, first, we're going to talk about health expenses and outcomes. How does the United States compare? And then we're going to talk about earnings and health, racial disparities and health, private for-profit health insurance, then fifth, public health insurance, and then personal behavior and health. And the question behind all of this, obviously, is inequality. What are the consequences of everything we talked about in the first half of the course? So how does the United States compare? Which statements about the United States healthcare system, which statement is true? There's only one statement up there that is true. I want you to look at these statements. A, Americans live longer on average than the citizens of any other rich country. B, on a per capita basis, the United States spends more on healthcare than any other rich nations. Or C, as a percentage of GDP, the total economy, United States healthcare spending is now half of what it was in 1980. Go. Which is true? Let's see what you said. Okay, 58% of you say it's B, on a per capita basis, the United States spends more on healthcare than any other rich country. But a lot of you think it's C, healthcare spending is now half what it was in 1980. A is obviously not the case. Most of you did not think it was A. It is B, but let's take a look at the data. It's always convenient to look at what the data actually is. This is comparative life expectancy at birth. Now, the United States has the lowest life expectancy at birth of all advanced countries. And let's just look. I mean, if you can see here, that's the comparable country average, and then the United States is down there. And then you look at other countries have much, much longer life expectancies. And what about health spending per capita? Well, again, on the left, you see the United States and then Switzerland, Germany, all the way down the United Kingdom. We're just looking at rich countries, relatively rich countries. And the reality is that the United States spends far more per person on healthcare. So how can it be? This is the puzzle we'll begin with today. How can it be that the United States spends on a per person basis far more than any other rich country on healthcare, and yet is one of the worst in terms of life expectancy? I mean, it's sort of an interesting puzzle. How can that possibly be? And how do a lot of the things we've already been talking about fit into solving this puzzle? And what are the public policies that are implicated here? This is an interesting graph. We kind of rank health system performance. Down here is very bad performance. That is where you get a lot of people who are quite sick, a lot of people who die early. This is great performance, just the opposite. People stay healthy and have long life expectancies. And then over here is healthcare spending as a percentage of the economy. And over here, you've got the extreme is 18%, and here's 0%. So let's look at this particular graph and see where the United States fits. Now here's the United States. That's called an outlier. Here is Canada, France, Switzerland, Sweden, the United Kingdom, New Zealand, Germany, Norway, Netherlands. Now, all of them are clustered here. That is, they have, they're spending about 10 to 12% of their entire economies on healthcare, and they're getting, relatively healthy outcomes. Again, why is the United States such an outlier, spending huge amounts and getting such lousy results? Well, let's take a look at what we have spent over time. Maybe that will help us understand what's happened. Here we're going to start with 1970 and move right up to 2016, 2017. Now this is obviously before the pandemic. And here you can see on this scale is health consumption expenditures as a percentage of the entire economy from 0 to 18. Now let's see what's happened. Every other country has been spending more money on healthcare, as you can see. Over time, since 1970, healthcare spending as a percentage of their economies keeps on going up, but the United States is going up faster than anybody else. Well, that gives us a clue. There's something that is happening here that is different from every place else. Every place else is spending more, but we're spending more than more. Does this give us a clue? Well, maybe. This starts at 1980, goes up to 2015. Again, all pre-pandemic. This is annual retail prescription drug spending per person. There's the United States, and here are the others. Well, prescription drug spending may be part of the cause. I mean, if you just look at the numbers here, this doesn't explain all of it, but it may give us some indication of what is happening. Let's take a look at the theme of this course, obviously, is wealth and poverty, widening inequality. Does this give us any hint at what's happening? This here is a chart that shows here are years an adult can expect to live after the age of 25. So if you are up here, you're going to live to 85. You're down here, you're going to live to 55 on average. And here's family income, and we're doing it as a percentage of the federal poverty level. And let's take a look. Well, there's definitely a correlation here. That is, if you are 400% of the federal poverty level, you're going to live longer. If you are down here at the federal poverty level, you are not going to live as long. Well, that's interesting. It's not too surprising, but how does this relate to what we just saw in terms of huge federal expenditures and lousy outcomes? Well, maybe we can puzzle this through. Maybe we can understand it if we just keep trying to understand it. Education seems to have something to do with life expectancy. We're going to be talking about education, and we've already talked about education, but what can this reveal to us that might solve this problem? In this particular graph, where it's comparing life expectancy at age 25 by gender and education level, and we're talking about 2 years, 1996 and 2006. We could have picked a lot of different years. This just shows us a trend line, that's all. And we're comparing men and women. And then we're also looking at no high school diploma or high school, some college, or bachelor degree. So in this one graph, we're trying to do a bunch of things. We're trying to see a bunch of things, a lot of variables. These kinds of graphs are a little bit hard to read because there are many variables. And you graphophobes, I understand. Bear with me, because this is important. What you see here is that if you compare 1996, for example, men with no high school diploma, their life expectancy at age 25, they've had only 47 years more to live. In 2006, no progress. No progress at all. They remember from our former graphs, you saw huge increases in expenditures, health expenditures, but no progress whatsoever. Women, well, there's a little bit of, actually, women went from 53% if they have no, 53 years if they have no high school degree, to 52, statistically not significant. But what this shows us is that educational levels are not only correlated to how long somebody lives, but they don't seem to be changing very much in terms of those correlations. Income and health gap is widening. Life expectancy at age 65 by earnings. We're going to compare here the top half of earners with the bottom half of earners. And we're looking at life expectancy. We did this a little bit, you may remember, when we talked about tax policy, and we were talking particularly about Social Security. But I want to bring it to your attention again in this context, because something is happening that is changing. That is, we're seeing a divergence. We're seeing a situation that we might not have liked in 1977 because there was a gap growing, but the gap is getting larger. Now, this particular graph does not go beyond 2007, but you can expect, knowing the direction it was going in, that it's going to go in the same direction. That gap is widening in terms of life expectancy. So why is the income health gap widening? Is it the top half sees physicians more often, A, or is it B, they can afford more expensive drugs and procedures? Or is it C, they take better care of themselves? Or D, is it something else? What do you think? Go. Okay, let's end the bidding there, and let's just see what you think. So most of you think they can afford more expensive drugs and procedures. That is about 62% of you. The next one is A, they see physicians more often. Most of you don't think they take better care of themselves as the key explanation, the key variable. But here's what we know, and we'll get into this. Preventive health measures, that is, preventing heart disease and diabetes, and to some extent cancers, before they occur, is the best way of protecting health. Preventive health care. The way you do that in our system is you see a physician. Ideally, there is a family physician. Ideally, there is somebody who you see regularly, ideally once a year if you're an adult. That is the best way of staying healthy in terms of preventive tactics. So why aren't they doing that? Because, hello, a lot of people can't afford it. This is not rocket science. Here we're going to be looking at more than 1 in 10 adults in the United States did not see a doctor when they were sick because they cannot pay for it. And we're going to look at dental care, seeing a doctor at all, prescription medicine, seeing a specialist, and so forth. Let's just look. A very significant percentage, 18% of Americans, do not have dental care regularly because they cannot afford it. You see about 12% don't see a doctor because they can't afford it. Don't get prescription medicines. Don't see a specialist. Follow up. They can't afford it. It's not that they don't care. Who is obese? This is every time I talk about or argue about the importance of people seeing a physician or at least being able to afford health care, somebody says, well, but people don't take care of themselves. Well, if you want to blame the victim, you can. But what you need to do always is understand why people don't take care of themselves, if in fact they are obese, or if there is a relationship between obesity and income, which there is. But that doesn't tell you why there is a relationship between obesity and income. And it doesn't tell you or reveal to you the context. And this is data that is very, very often used. So the wealthier you are, chances are the less obese. The poorer you are, chances are the more obese, and so on. And you can also see that obesity, sedentariness, and diabetes all sort of go together. But go deeper. Why are so many poor people obese? Why do they have diabetes? Could it be, for example, that they don't have ready access to good food and nutrition? Could it be that they don't have time or money to do anything other than sort of fast food? Could it be that they don't see a physician who tracks their potential for diabetes? You can, if you understand the sociology of poverty, and we've been talking about it in this class, you understand, if you want to blame the victim, you certainly can, but that doesn't get you far in terms of your understanding of what's actually going on. You can also look and track child obesity and the education of the head of the household, which is interesting because it means that children, poor children, are not necessarily obese because they are careless, because they want to be obese. Maybe there is something going on in terms of the capacity of that household, in terms of education and income, and we know about the relationship between education and income. Maybe there's something about the capacity of that household to actually provide an environment in which children are getting enough exercise, are getting the right food. Which of these statements is true? Only one of them is true. A, in the years 2000, 2002, 2017, death rates rose for Black and Hispanic or Latinx people. Or B, recent death rates are up for younger whites, down for Black and Latinx people. Or C, deaths from COVID-19 have been about the same for Black and Latinx people as for non-Hispanic people. One of these statements is true. Which is true? Go. And let's see what you think. So almost 90% of you believe it is A. That is, death rates in this interval of time rose for Black and Hispanic or Latinx people. Not many of you think it's B, and almost none of you think it's C. Well, let's take a look. I mean, there's nothing better than looking at the data. Figure it out. Death rates by race and ethnicity, 2000 to 2017. And again, we're looking across the bottom. This is your year. This is your deaths per 100,000 population. It turns out death rates actually dropped for everybody from 2000 to 2017. They dropped for Hispanic, Latinx, they dropped for non-Hispanic Black, they dropped for non-Hispanic White. Obviously, they started at a different rate. You can see they are higher for Black people than for white people, but they dropped, all of them. What about the percent of people with a friend or a family member who died because they couldn't pay for medical treatment? Well, let's take a look at this by race. And you can see here, by the way, we're looking at white versus non-white, and income, and I don't know why political party is relevant, but the percent knowing a family or friend who died due to their inability to pay for medical treatment. Well, you see very big disparities between white and non-white. You see big disparities in terms of income. You see, interestingly, disparities in terms of age. And what about COVID-19? We just went through, and maybe are still going through, a deathly, horrible experience as a society. The rate ratios comparing to white, non-Hispanic persons, American Indians, Indigenous, Alaska Native, non-Hispanic, 2.8 times higher in terms of cases, 5.3 times higher than white people in terms of hospitalization, 1.4 times higher in terms of death. And you can see all the way along. Black Americans, 4.7 times higher hospitalization, more than twice the rate of death. Nearly half of Black Americans say they have been afraid their life was in danger due to their racial background. And here we're looking at Black, non-Hispanic, and Hispanic and white non-Hispanic. Your life is in danger. You were stopped or detained by the police, and you are afraid your life is going to be in danger due to your racial background. You're denied a job, etc. What is it? Pretty significant differences. Doesn't mean that their life was in danger, but they certainly perceived it being in danger because of their race. That has to be factored in as well. Which makes all of this interesting. Those of you who thought that it was that in fact death rates were going up for Black and Latinx and down for whites, no, it's just the opposite. But let me warn you, this is based upon where we were. That is, death rates were already very, very high for Black and Latinx people, but relative to where we were, what we are seeing is you see Black death rates, age 25 to 34, compared to what they were, this is the baseline in 1999. All we're doing now is comparing to 1999. We're looking at what has happened to death rates since 1999. White women, since 1999, compared to 1999, their death rates are going up. White men, particularly young white men, ages 25 to 34, young white men, their death rates are going up. Again, this is just comparing to where we were. Why is this happening? Why are death rates increasing for younger white Americans? A, it's violence is catching up with the white working class, homicides and gun-related suicides. B, they are eating less well, drinking more heavily, smoking, exercising less, and becoming more obese. We're talking about death rates for younger white Americans. C, they are succumbing more to drugs and drug overdoses. What do you think explains this change since 1999? Go. And let's take a look at what's actually happening in your brains. A lot of you think it's drugs, drug overdoses. A lot of you think it's eating less well, drinking more heavily, smoking, exercising less, becoming more obese. Not many of you think it's violence. Let's take a look at the data, shall we? Opioids. We're starting in 1980. We're going here. The latest good data we have is 2015. It probably understates. And we're comparing Europe and the United States. Here we have Europe, and here we have the United States. This is oxycodone consumption, the consumption of opioids. The producers of opioids, including the Sacklers, were very successful at marketing to physicians and to the public, but really to physicians, the notion that you could have this painkiller that would not be addictive. Well, it was addictive. And doctors were prescribing it. And a lot of people succumbed to it. I had a cousin who had a very bad back. He was in terrible pain. And he got addicted. And he died. Drug overdoses are lowering lifespans. Here we can see where the rates of overdoses are very high. This is per 100,000 people, so we're looking at rates. And what do we know about these areas, West Virginia and Kentucky and Tennessee, Oklahoma, and these western states? We know that these are poor people. We know that these are poor Native Americans. We know that these are poor people, poor white Americans, poor black Americans. Drug overdoses. There was a recent, quite famous research and paper done by Ann Case and Angus Deaton that talked about, but the two of them talked about deaths of despair. People are dying, and they looked at non-college versus college. And they tried to understand, starting in 1992, they had a very, very big data set. They tried to understand what was going on. The number of deaths of despair per 100,000 white people aged 45 to 54. Not much change for college graduates, but a dramatic change for non-college graduates. Now, what you ought to be thinking about, going back to the first part of this semester, when we talked about what was happening to jobs. And we saw, particularly for white men, a dramatic decline in incomes. This is not just drug overdoses. This is also opioids. This is also suicide. Which brings us to how we pay for all of this. How do we actually keep people healthy? Now, having seen everything you have seen, understanding everything you understand, we're now getting into the trenches of public policy, but I want you to have the context you have to understand what the current debate is, or what the debate should be. Which statement about costs of private health insurance is true? A, the cost of premiums is rising at about the same rate as the median wage. And by premiums, I simply mean the cost of having a health insurance plan, private health insurance, which most people depend on. Or the cost of deductibles is rising about the same rate as the median wage. Deductibles, how much you have to pay before your insurance pays. Or C, the cost of premiums is rising faster than the cost of deductibles. Or D, the cost of deductibles is rising faster than the cost of premiums. All sounds very complicated. It's not, and it's very important. What do you think? Go. And most of you are saying the cost of premiums is rising faster than the cost of deductibles. Well, let's take a look at how fast everything is rising. Now, the reason that this is so interesting compared to the median wage should be obvious. We're talking about how people can afford or not afford this. Premiums are rising faster than wages. Well, we can see this quite obviously. And we're starting at 2000, we're ending about 2020, and we're looking at the average annual earnings of the bottom 90% and premiums, even for employer-provided health insurance. And you can see that premiums are rising very fast. It's harder and harder to afford health insurance, even if it is employer-provided, because employers are requiring workers pay more and more. Deductibles are rising even faster than premiums and wages. Take a look. And again, deductibles, I want to stress this because you don't hear enough about it. Deductibles are what you have to pay before the insurance company pays. More and more and more of your medical bill you have to pay before the insurance kicks in. This is a huge and growing cost to American families. It's not talked about nearly enough. And can you imagine if you are poor? Going back to several slides ago when we talked about people who could not afford it, they cannot afford to pay these deductibles, even if they have insurance. Here we're looking at total compensation. That is, what you as a worker are bringing in and your earnings. Starting in 1970, going through 2016, and here's what you see, and I want to stress this, because the real compensation, that is, adjusted for inflation, compensation is going up, but your actual average hourly earning is not going up. Why? Because so much of your compensation is going to your health insurance, if you were in the private sector, if your employer is providing health insurance. So one of the clues to the puzzle we had, why is it that wages have stagnated for so many people for so long? One clue is in this chart, because this shows that more and more of your potential wage is actually going to paying for health insurance. Employer-provided health insurance, even before COVID, was dropping. It was declining very, very rapidly. Employers are under no legal obligation to provide it. It was provided because it was customary or because it was in labor contracts. But go back to our session on labor, and you remember in the 1950s and 60s and 70s, a third of the labor force was unionized. Health insurance was part of the contracts they negotiated. Today, 6% of the private sector workforce is unionized, so they don't have the power to get quite the contracts they had before. But also, as you remember from the first part of the course, employers are under greater and greater pressure from Wall Street to show profits and higher share prices. So why would they offer, unless they had to, health insurance? Or unless they were dealing with the quote-unquote talent. Going back to Chainsaw Bob. So what's the primary goal of private for-profit health insurance? That is the dominant form of health insurance we have today. Private for-profit health insurance. What's the major dominant motive, primary goal? Is it to give the public the highest quality and lowest cost health care possible, A, or prevent chronic illnesses before they occur by helping individuals take better care of themselves, screening to detect early health problems, B, or sign up healthy people and avoid sick people? Go. And let's see what you think. A lot of you think it's sign up healthy people and avoid sick people. You cynical students. Well, it is. But let's not demonize health insurers as being immoral, because that's the way they maximize shareholder value. And they are under pressure to maximize shareholder value. They're under pressure to maximize profits. How do you maximize profits? Well, are you maximizing profits by insuring a lot of very sick people? No. You're maximizing profits by finding the healthiest people you can possibly find. You remember going back to our session on the sorting mechanism? This is the sorting mechanism again. But step back from all of this. How can you justify, in public policy terms, a health insurance system designed to avoid sick people? Isn't there something slightly ironic about that? Now, this is why, by the way, in the Affordable Care Act, which we'll get to in a moment, one of the key features of the Affordable Care Act is insurers must insure people with pre-existing conditions. If you have a pre-existing health problem, insurers have got to provide you health insurance. They cannot discriminate. But there are ways, nevertheless, that private health insurers find ways of marketing health insurance to groups of healthy people and not marketing health insurance to people who are likely to have or be sick. Which gets us to public health insurance. We've talked about private health insurance. What about public? Now, these are countries that provide universal health care. Not entirely universal. They all have slight variations. But the United States, again, is an outlier. This is not new, by the way. Franklin D. Roosevelt, in the 1930s, in the New Deal, wanted to provide health insurance as part of the Social Security Act of 1935, could not get it done. Why? The American Medical Association accused Roosevelt of being a socialist and put on a major campaign, publicity campaign around the country against national health insurance. Harry Truman became president. He was FDR's vice president. Franklin D. Roosevelt died. Harry Truman tried to get universal health care. The British, after the Second World War, they established the British healthcare system, which was essentially free to everybody. They were very proud of it. The argument in Britain was, we have been through a war. It has been a huge public sacrifice. The least we can do is to have public health care. Harry Truman tried the same argument, couldn't get anywhere. Socialism. Even Dwight Eisenhower, Republican, in the 1950s, tried, couldn't get anywhere. The first president to get somewhere was Lyndon Johnson in 1965. 1965, with Medicare and Medicare's poor cousin, Medicaid. In the United States, the government doesn't provide universal health care. It doesn't directly provide health care. It doesn't pay for most people's health insurance, except for the elderly and the poor through Medicare and Medicaid. Health insurers and providers are mostly private and for-profit. Why is the United States so different from every place else? A, Americans are more reluctant to give the government power over personal health, or B, private physicians and hospitals have more political power in the United States, or C, healthcare in the United States started with private for-profit entities. Maybe is that what it is? Or America doesn't have enough physicians, nurses, and other health professionals. What is it? Go. Let's see what you think. Well, you're confused. No, you aren't confused. These are all reasonable. That is, there's a lot of evidence that Americans are more sensitive to centralized power. It could be argued that the period of time from the First World War, that is from the Depression, 1929 was the Great Crash, certainly through the 70s, that was a kind of an exception to the rule. Americans don't like big government. They like and feel like individualism is very important. But what about private physicians and hospitals having more political power? They do have extraordinary political power. As I indicated to you, the American Medical Association is very, very powerful. But you now have nurses who are also very powerful. They are actually very often pulling in the opposite direction. And healthcare in the United States started with private for-profit entities. No, it started with private not-for-profit entities. Now, this is sort of an interesting story. I don't want to get too far into it, but when private health insurance started in the United States, Blue Cross and Blue Shield, the big private insurers, were not for profit. Why did they become for profit? Because they were competing with a few upstart for-profit insurers. And what happened on the principle of for-profit insurers looking for healthy people and trying to avoid sick people? All of the sick people started going to the nonprofit Blue Cross Blue Shield, driving up the costs to the point where they couldn't be in existence anymore. And so we don't have private nonprofit entities. And it's true we don't have enough physicians, nurses, and other health professionals, but that would imply or suggest that we pay them more, or pay people more to go into these professions. But then who's the we? In 1965, we get Medicare and Medicaid. This is revolutionary. As I said last week, when we talked about whether poverty is a policy choice, poverty among the elderly had been endemic in America. And in 1965, Social Security was expanded, and more importantly, for our present purpose, Medicare. If you are over 65, 67, you are eligible for Medicare. In fact, if you look at Medicaid and Social Security and veterans benefits, veterans also get a particular form of public support. You get to about 48% of the population has government, public medical insurance. When Bill Clinton became president, he thought, and his wife at the time, in fact, still wife, Bill Clinton's wife, Hillary Clinton, at the time, she thought that there ought to be, and Bill Clinton ought to be able to get a public health insurance, universal health care. And so I remember the day I went down to Little Rock right after he was elected, and I was in the kitchen of the mansion in Little Rock. And they were talking, both of them, about healthcare. And I said, are you really going to tackle this? This is a big one. I mean, and I gave them a little of the history. They knew the history, but I went in some of the details about how difficult it is politically to get this done. And they thought it was still very possible to do it. I said, you've got to keep it very simple. I mean, the reason Medicare was done is because people could understand it. It was modeled on the same principle of Social Security. That is, you pay it as part of your wages, and, it's just not complicated. Hillary also said to me, well, I think I understand, and I'm going to put in charge of this a fellow who you know, Bob, very, very well. I did. I'm not going to name him here. It would be inappropriate. Ira Magaziner. I said, don't do that, because Ira is brilliant as a policy person. He's a brilliant policy mind, but he's politically tone deaf. Do you understand the difference between brilliance as policy and brilliance at politics? I teach in a school of public policy. I think it's very important that people understand public policy. But if you don't understand politics, you can come up with fabulous policies that will never get enacted. And so Bill Clinton in 1993, going into 1994, and Hillary, they came up with the most complicated healthcare plan you can possibly imagine that Ira Magaziner created. And it was brilliant, but nobody understood it. I did not understand it. I spent a whole week with Ira Magaziner, and I spent days with Bill and Hillary trying to understand this plan, and I was not alone. The entire cabinet, we were all there. We could not understand it. I think it worked, but who cared? Because if we can't explain it, if you cannot explain a policy to the public, forget it. And the policy, the idea, the whole complicated, elaborate framework was scuttled by Congress. Even the Democrats in Congress, who then ran both the House and the Senate, they said no. And that contributed to Bill Clinton and the Democrats getting shellacked at the midterms in 1994. More than half of state tax revenues fund education and health care. You should know this, because a lot of it goes to Medicaid. And you can see here, you've got higher education, and you've got Medicaid and children's health, and you've got K through 12 education. And this is everything else. But if you look at the budgets of states and where more and more expenses are coming from, it's health care and it's education. And the health care is Medicaid, primarily Medicaid. Barack Obama signed into law the Affordable Care Act in 2010. And you can see how happy people are. This man... Now, explain to me, why does he have a bald head here, and he doesn't any longer have a bald head? This is an interesting policy. It's not a policy issue, actually. The provisions, you probably know, subsidizes individuals and families up to 133% of poverty level. This is where, remember, all our discussion about where the poverty line is becomes so important. Because 133% of the poverty line maybe sounds like a lot. We're talking about just a little bit above the poverty line, and requires insurers to cover people with pre-existing conditions, thereby avoiding the sorting mechanism I mentioned before, allows children to remain on parents' employer plan until age 26, which some of you may be taking advantage of, or maybe you will take advantage of. And all of this is very important, and it's helped a lot of people. It has also expanded Medicaid for the poor. Medicaid is a program focused on poor people. But here's the problem. States have to opt in to Medicaid in order to get the Medicaid expansion in the Affordable Care Act. And you can see here, there are a lot of states that have not opted in. What do we know about these states? Well, you know a lot about these states. Even though it's very cheap for states to opt in, even though the federal government takes most of the cost, these states still refuse. Interestingly, deaths among low-income older adults fell sharply after Medicaid expansion in the states that expanded Medicaid. I mean, this is one of those issues of poverty, and in this case, death, is a policy choice because we can compare. We've got a control group. You can compare two different sets of states. One group of states expanded, and the others did not expand Medicaid. And this is the annual change in deaths for 10,000 people in states expanding Medicaid. And you can see here is pre-expansion and here is post-expansion. I mean, if you have ways of saving people's lives, presumably, depending upon the cost, it's a good public policy, depending on the cost. Medicaid also has been shown to reduce medical debt. I want to just stop here for a second and talk to you about something. One of the biggest sources of bankruptcy in this country is people who cannot pay their medical bills. And they can't pay their medical bills for all of the reasons we've seen. So they go into bankruptcy, their credit is destroyed, they reorganize whatever they earn to pay doctors and hospitals and others who are making claims on them. It is a cycle of poverty. It is a cycle, a vicious cycle in which many people find themselves. Average medical debt, you can see again, depending upon where Medicaid was expanded or where it wasn't expanded, big difference in terms of medical debt. Who pays for the Affordable Care Act? Well, it is actually a very progressive tax. We talked about progressivity and regressivity. This is a progressive tax. Higher Medicare taxes on incomes over $200,000 and $250,000. 3.8% surcharge on capital gains of high-income individuals and families. Go back to our discussion of taxing. You know exactly what we are talking about here. And also individual mandate that required everyone, even young and healthy, to be insured or pay a penalty. But that was ended by the Republican and Trump administrations in 2019. Many people thought that was going to be the end of the Affordable Care Act, by the way. But it turns out that a lot of young people continue to buy health insurance. And the redistributional progressive aspects of the Affordable Care Act, pretty impressive. The bottom tenth gets a lot of benefits, and it comes from others. You don't see this very often. So where should we go from here on? A public option? Some people say public option. That's what I was testifying about before the House 3 weeks ago. A public option with Medicare should be available to anyone who wants to buy into it, but anyone who prefers private for-profit insurers should be allowed to sign up. Or should it be a single payer? End private for-profit insurance altogether and have government be the single payer to doctors, hospitals, and pharmaceutical companies? Or keep the current system, at least until we have more experience with the Affordable Care Act? This is the debate right now in the public and on Capitol Hill. What do you think? Go. End the bidding and see where you are. Well, there's not a huge difference. We've got about 50% of you want a public option, and if I read it correctly, about 47% of you want a single payer. Not many are in favor of keeping the current system. This is a more radical change And we'll get in a moment to the argument for this. The argument against this is that such a radical change. And the second argument against this is, why trust the government? Argument in favor of this is, well, we already have Medicare. Why not just make it available to anybody who wants to buy into it? The argument against this is, well, wait a minute. If anybody can buy into Medicare, that's going to give Medicare huge economies of scale that private insurers don't have, and that means that a lot of people are going to leave private insurers. That's not really much of an argument, is it? That's also an argument, but you don't really hear that argument. Interestingly, this was the argument in the 30s. I heard the argument in the 1950s and 60s. It's not really there anymore. This is the big issue, and I want to stress this with you. The administrative costs of even Medicare, the administrative costs, when I say administrative costs, I mean the costs of accounting, of private insurance, the administration of billing systems, the administration of marketing, promotion, all of that takes a lot of money. You don't have those administrative costs in a single payer system. That is the big advantage of a single payer system. In fact, if we look at other countries and compare the administrative costs of healthcare spending, something bounces out at you. Administrative costs are far higher in the United States. And you have only, to talk to anybody in a hospital. My brother-in-law and sister-in-law, they are both nurses. And I often talk, in fact, my brother-in-law was visiting, and I asked him about what he's got to do. How much of his time does he spend on billing? Just billing insurers, just keeping track of how his time is organized and which of the things that he is using go to which insurer. He said 1/3 of his time. And then I checked with all the data I could find, that's about it. 1/3. 1/3 of all of the time of nurses in our system is spent just on billing. We can't end our discussion simply with public or private health insurance. What is your major health issue? Now remember, this is completely confidential, except for the CIA. Okay, let's end the bidding now and let's see what your major... Well, your big issue is you don't exercise enough, you say, and you also say you consume too much alcohol. One of the biggest public health victories, and there are public health victories, one of the biggest public health victories was the decline in smoking. Now, when I was growing up, every adult smoked, or just virtually every adult, and every living room I went into always reeked of cigarette smoke, and there were ashtrays everywhere. And, I even as a kid, I thought it was kind of awful, disgusting. Well, in 1964, the Surgeon General of the United States came out with a report linking, for the first time, with evidence, smoking to lung cancer. And that was one of the few examples I can come up with in my mind. There are others where a report, a public policy investigation, good data, changed or began to change the public's attitudes and norms. And you can see here a dramatic decline in cigarettes and also cigars. Bill Clinton smoked a cigar. But cigar smoking is sort of passé, as is cigarette smoking. When I was Director of Policy Planning in the Federal Trade Commission in the 80s, one of the things that the Federal Trade Commission had been doing for years is putting warnings on cigarettes, saying you could die of lung cancer if you consume this product. And the Federal Trade Commission's warnings became ever louder and ever more, explicit. I mean, there were almost skulls and crossbones on cigarette packages. And then finally, when I was, and we did a lot of that, but then when I became Secretary of Labor, I thought this is an opportunity, actually under the aegis of protecting the health of American workers, the Occupational Safety and Health Administration, maybe what we could do is pass a rule that required employers to have no smoking. And they would have a separate facility for people that felt that they needed to smoke, to protect all of the workers who were not smoking, because passive smoke was also shown to be a health problem. Passive smoke, that is, if people around you are smoking, it affects you, it affects your lungs. So I and my colleagues proposed this rule, and you would have thought that we proposed communism. I mean, the reaction from, not surprisingly, the Restaurant Association, the bars, all of the places that depended on patronage, and the patronage sort of liked smoking or did smoke, was huge, hugely negative. We could not get this rule off the ground. But as a measure of how times have changed, this rule is the standard in most states. Smoking correlated with income? Yes, it is. And again, beware before you blame the victim. Think about the social context in which people are smoking. Teen vaping. Vaping has gone up. There was this mythology for a while that vaping would not hurt you. Vaping was sort of a harmless way of smoking. Well, it was mythological. It is mythological. And we have a lot of new data that shows that vaping and lung illness are very closely related. And so if you are, or you know anybody who's vaping, you might want to suggest this to them. The top markets for vaping products, guess what? What I hope you are doing as we go through this information is you are solving puzzles that I revealed to you in the start of this session. Why is it the United States has such terrible health outcomes? Well, a lot of people can't afford to see physicians. There's not preventive medicine. The public insurance system is filled with holes. A lot of people are doing things that are harmful and are hurtful. What about traffic deaths? What about traffic deaths? Is that part of our healthcare system, or certainly our healthcare problem? Of course it is. What do we know about traffic deaths? Well, let's take a look. I mean, if we're looking at 1980 to 2020, annual percent change, the percent change from each year. Are they going up or down? Last year, a big increase in traffic deaths. There's not good research on why. My guess is that, like everything else, people are stressed out. The pandemic had an effect, but not good research. We don't really know. What else should we be looking at? How about gun deaths? Part of public health? Yes. A public health problem? Yes. Does it affect poor people more than wealthy people? Yes. Let's take a look. Starting in 1999 through 2017, number of U.S. gun deaths in the United States due to firearms. Is that a trend that has a bearing upon short lives? Of course it does. Does it have a bearing upon short lives among the poor? Of course it does. And how do we compare in terms of gun-related death rates per 100,000 population? You can't see it very well. This is South Korea, Japan, etc., etc. Well, let's take a look. Homicides and suicides. The United States leads the pack. Now, I'm not giving you this information to depress you. I'm giving you this information to inform you about what the state of health is in this country and why. So what are the public policy options here? We talked in terms of public policy options with regard to health insurance. A lot of debate in Washington and elsewhere about such things as opting in or not opting in, a public option for Medicare, or a single payer plan, or any of these other things, but not, in my view, very much debate about what we've just looked at. Healthcare systems should emphasize preventive care and improve public awareness. Sin taxes, we've looked at sin taxes, cigarette, alcohol, soft drinks, obviously reasons not to do that, but there may be some negative, positive behavioral results of doing it. What about sugary soft drinks and prevent junk food from being sold in public schools? Well, there is a debate about that, and some public schools are banning it. What about restoring physical fitness and gym programs to all public schools? What about more sidewalks? What about making it harder to obtain guns? I mean, there are all kinds of things that could be done, and this is just a small sampling. But if we really thought broadly about the health of our society and understood that our lousy health outcomes in terms of small lifespans relative to other rich countries is related to many factors that are within a society's power to control. And if we understood that all of this affects the poor to a greater extent than anyone else, maybe under the banner of poverty as a policy choice, we could do a lot more than we are doing. So, just summarizing, poor health can cause or perpetuate poverty. Public policies are expanding access to health care, but many of the poor still do not have access to health care in terms of seeing a physician and having preventive care. Systemic racism underlies much of the health gap, as we have seen. Some of the personal problems and limitations associated with poverty may also contribute to the bad health of the poor. Public policies can be of help. Now, this is not by any means the end of the discussion. We're going to talk about climate change and health outcomes and what is climate change doing to the poor. These are all problems that are amenable to solutions. Explanations are not justifications. Have a great weekend, great week. See you time.